All right, and welcome back to another episode of We Good. It's the virtual town hall series hosted by the African American Leadership Forum. My name is Brittany Wright, and I want to thank you all for tuning in for another conversation on COVID-19 and the Black experience. Today, we're focusing on vaccines, Black maternal health, and medical distrust. Before we get started, I want to say a special thank you to our sponsors, which include the Minneapolis Foundation, North Point Health and Wellness, and Children's Minnesota, who all come together to make this town hall possible. And I also want to give a special thank you to our partner organizations who come behind the scenes and help us produce this show every 2 weeks. That includes North Point, Children's Minnesota, Insight News, the Minnesota Spokesman Reporter, and Minnesota Community Care. On today's panel, I am joined by Ms. Adrienne Thornton, who is a nurse and infection preventionist with Children's Minnesota. Welcome, Adrienne. Welcome. We appreciate you being here. Also joining us is Ms. Georgia Fort, who is a producer and correspondent. Welcome, Georgia. Thank you for being here. Also joining us is Dr. Rwanda Campbell, who is an OBGYN at the Glacial Ridge Health System. Welcome, Dr. Campbell. And also joining us is Dr. Zeke McKinney, who is an occupational physician and has about 7 other titles and is coming today to really help ground us in vaccines as it relates to COVID-19, as well as the Black experience. Welcome, Dr. Zeke McKinney. And last but certainly not least is Dr. Lavonne Moore, who is a nurse practitioner at North Point Health and Wellness, but is also the CEO and founder of Chosen Vessel Midwifery Services and provides a variety of services to expecting mothers and new mothers as well. Welcome, Dr. Moore. Glad to have you. So we're here having this conversation today, focusing on medical distrust, the COVID-19 vaccine, and Black maternal health. We're doing this because Black women are 3 to 5 times more likely to die during childbirth than any other group of people in the United States, especially their white counterparts. Black infants are 2 to 3 times more likely to die than white infants, and we know that the Black infant and maternal mortality standards here in the United States are caused by bias within the medical system. Up to 60% of these deaths are preventable, and really it comes down to believing Black women, hearing Black women, and establishing better relationships between those who are practicing medicine and those who are receiving care. And so what we're going to address in today's conversation is, how do those statistics vary when we're in the middle of a pandemic? We also know that Black people are disproportionately impacted by COVID-19. And so we have all of these barriers and comorbidities working against us simply by our racial makeup. And then we also have medical bias and a long history within the medical system of Black bodies being experimented on, not treated with respect, and we see the results that we have now. So here to ground us in all things COVID and set the scene for how we even talk about Black maternal health in a pandemic, I'm going to pass it to Ms. Adrienne Thornton.
Good morning, everyone. So the data is still unsettling in terms of how much COVID we're seeing in the nation as well as the state. So we're up to 6,800,000 cases of COVID-19 in the United States. And just to kind of give you a little perspective on that, at our highest rate in July, we were seeing about 74,000 new cases per day in the United States. And we're down to between 34,000 and 40,000 per day, but that is still a lot. It's about half of what we were seeing at our highest peak, but it's still a lot. And for deaths, we're going to top 200,000 most likely in the next 24 hours once the reporting gets updated, which is very alarming and very sad. That's 200,000 people who have died. There's 200,000 people who will no longer be with their families and their friends and working and contributing to society. So that is a lot of people. And then when you look at Minnesota, we're still seeing high numbers there as well. We're up to 92,000 cases as of this morning, and almost 2,000 deaths. We're at about 1,900. And just for a little perspective, because I'm still hearing conversations comparing this to the flu, for the flu season from 2019 to 2020, we had 153 deaths related to flu. And we have already surpassed that greatly in just 7 months of monitoring with COVID-19. So people really should stop comparing this to influenza, because they're very different organisms, they're very different viruses, and what we have available to treat and manage the diseases is very different. And definitely COVID-19 is having a larger negative impact on the country as well as our state. And we continue to see in Minnesota that even though we comprise, Black and brown people comprise about 7 to 8% of the population, anywhere from 16 to 20% of the positive cases are in Black and brown people, and the deaths are a little bit higher than in the white population as well. So it continues to be a concern in our state and in our minority populations, and we need for people to realize that, take it seriously, and really look at how they are reintegrating into the community, especially with the schools reopening. We still have to be careful with doing our 3 W's. Wear your mask, wash your hands, and watch your distance.
Thank you, and that's incredibly important as we think about there is back to school, and so some parents are having an increased level of exposure now because their children are back in schools interacting with other people and maybe haven't gotten that much outside interaction since the shutdown happened early this spring. And so what we're seeing now is all of us having to shift our behaviors, right? We're wearing our masks, we're doing the increased hand washing, we are mitigating risk by considering like who we allow into our space and who we don't. But for some people, going into the doctor's office is still a non-negotiable. Going outside of the home is a non-negotiable, and that's especially true for Black mothers and expecting mothers. Do you have any data that points to how COVID is impacting expecting mothers?
Yes, the CDC just recently published data on the women that they've been doing surveillance on. So there are about 598 women that were hospitalized related to COVID, and 50% of those pregnant women had symptoms. And so even though we're seeing asymptomatic carriage in a lot of women, we are also seeing a lot of symptomatic pregnant women. And about 16% of those symptomatic women resulted in ICU stays, and 8% of those symptomatic women ended up being on a ventilator while they were pregnant and trying to deliver. So it's quite serious and quite dangerous for our pregnant women. And if they're feeling ill, if they're not doing their regular OBGYN visits, they need to start back doing those. And you can do them virtually, but if they develop any symptoms that they realize are new symptoms or different symptoms, they need to immediately contact their physician. And then in terms of how it's impacting our communities, out of those women that were hospitalized and symptomatic, about 43% of them were Hispanic and 27% were Black compared to 16% white. And so what that's saying to us is that it's impacting our Black and brown communities much more than it's impacting other communities. And we already knew that. We see it, we live it every day, but we now have the data to support that. And the sad part is that out of all those women, 10 did not result in live birth. And so 10 may seem like a small number, but if you're one of those 10, that is huge. If your family is related to one of those 10, that is huge. Loss of a child is always a very sad, very sad situation. But to imagine you're in a pandemic, your family can't visit, you're ill, and you have to go in the hospital as a pregnant woman because you're ill, and then to lose your child on top of that, that is devastating. And so just know that it is a serious situation for pregnant women, and we need to really be looking out for them, making sure they're getting the care they need, when they need it, where they need it, whether it's virtual or in person, but definitely providing that care for our pregnant women and looking out for them.
Thank you. That is absolutely devastating. And I hope that there are measures that can be done to prevent those numbers from continuing to increase. Someone who's joining us today has been working with pregnant women throughout the pandemic. Even when the rest of the world shut down, she was still answering the call to make sure that these expecting mothers were cared for. Dr. Campbell, can you speak to your experience of caring for expecting mothers during the pandemic and what you've seen in terms of how COVID has impacted their experience?
Yes, I would say it has really been a challenge. And as you were saying, Adrienne, thank you so much for that data. That data certainly reflected our experience here in Minnesota. I primarily work now in St. Cloud, Minnesota, with where we have a large population of women of color. So our experience there was pretty, it changed overnight. Because what we mostly saw primarily were patients who were waiting to come in, even though we had educated women on if you have a fever, have a cough, or have any type of change in your symptoms, to come to the hospital. But because of that distrust some of the women in our community have, they would come later. So we unfortunately had cases at the beginning of the process where women would come in respiratory failure. So respiratory failure and having COVID, that led us to initially I saw the patients who we had to do an emergency C-section on and would intubate and would place in the ICU. So those, and so once that got word into their communities, it's like, oh my goodness, I'm really not gonna go, or some chose to come. So so once the reality became, how sick women could be, some of them thinking like, oh, it's not a big deal. Once they came, we cared for them. Then the community began to say, okay, we're gonna have to do those W's that you're talking about, really, washing our hands, washing our distance, wearing our mask. But as we also know, as well, though, also in our communities, it's just how we live together and how we congregate. And so it was just really a challenge for them to figure out when to come to the hospital. And then we even had to deal with the whole notion you probably heard about, well, if a mother has COVID, what's going to happen to that baby? So initially the CDC came out and said, take those babies from those moms and put them someplace else. And then the mother's like, whoa, I don't want my baby away from me. And so we had to regroup midstream, figure out like, you know what? These babies, not necessarily be taken from these mothers, because in 3 days when they go home, who's going to care for that baby? That mother is. So we had to kind of step back and say, okay, if you're going to have the baby in the room with you, then we'll keep the baby maybe in the isolate, but we need to make sure that we are educating you on how to ensure if you're going to breastfeed your baby is totally fine, but are you doing appropriate hand washing? Are you wearing your mask? The distance, it was an issue, certainly, with a newborn baby, but we had to make that adjustment. We're like, culturally, what does this mean for this family? Everything. So I think we had to, as the process was going on, we had to step back and say, gosh, are we really doing the right thing for our community? So now it had somewhat settled down in the summer, but now we are, as you talked about, Adrienne, the resurgence has reoccurred. So now, at least know, because now we are screening our mothers now. They're being screened prenatally, that 38 weeks, 39 weeks, they're being swabbed for COVID. So that when they come to the hospital, at least we have an idea now of who those mothers are. That's if they're asymptomatic, who those mothers are. And if they are COVID positive, then we know. And then also too, we can better care for them and better have a long-term, short-term plan for them and their family. So I think we'll be, quote, ready. No one really wants to be ready for this new surge, but because we have now hopefully doing more prevention with now having the mother screen before they come to the hospital, then we'll have a better idea. But I know when I go to work tomorrow, it's going to be a different place. The difference we are seeing, again, we're about to resurge. And so right now, along with saying the 3 W's, we're now starting to tell our mothers as well, gosh, get your flu shot as well and everything. So I'll stop there.
Thank you. So when you say that we are getting ready to have a resurgence, is that because we are heading into flu season and because things are getting colder, or what is the biggest fear in terms of why we think the numbers are getting ready to spike again?
I mean, I think the numbers I think the numbers are recurring, but just because the nature of there may have been some lacks in, like people call this the COVID fatigue. you know, as far as it goes, but or patients going back, I mean, kids going back to school. I just think we had done so well, may have gotten a little lax, and now it's just returning. And so we're now seeing just the opposite of that. It's going to be a little tricky during flu season because now anyone comes in with a cough or a fever, you know, cough, fever, you know, those things like, oh my gosh, does this patient have COVID? So it's going to be just a challenge for us to kind of figure out what they have, but we'll do the testing and we'll care for the patients, but he'll have to really be vigilant, even though people are experiencing this quote fatigue, COVID fatigue.
I will say, you know, COVID fatigue is a thing. I think I've experienced it myself to a point of like, I just miss my family. I just miss the life that I had pre-pandemic and the freedoms that come from that. And also, you know, thanks to this town hall, I remain grounded in the reality that COVID is still out there. There is no vaccine yet. You know, trials are happening, which we'll get to in just a moment. But it is important for people, regardless of how frustrated they are. You know, imagine how frustrated your children are and people who already have limited freedoms. And so it is important that we continue to be mindful because it's very scary. And the last thing we want is for somebody who's bringing life into the world to suffer a loss as a result of contracting something because you wanted to go to that block party or your barbecue or whatever it was. So I want to pivot now to Dr. Lavonne Moore, who also works with expecting mothers and ask, when it comes to labor and delivery, how are things different now if you are giving birth in a pandemic? To clarify, Dr. Moore is a nurse midwife and women's health practitioner. So Dr. Moore, how have things shifted in terms of labor and delivery?
Well, here we go. There we go. One of the main things that Dr. Campbell kind of covered is that whole hospital experience for women. I see women mainly in clinic in the outpatient setting, but in the inpatient setting, the support has been a big concern for many women, and they start talking about that at their clinic appointments, that they're concerned who can go to the hospital with them, how many people can be there. We're talking about with communities of color, often more than one person being there at their births, and so the rooms can sometimes get pretty full. And so people feeling very isolated by not being able to have more than one person with them. So that's a concern up front for many women that they talk about. And one of the other things that Dr. Campbell alluded to is the issue of breastfeeding, which is a big concern for me. It's a big part of the work that I do at North Point, as well as in my private practices. I have a chocolate milk club. I work to encourage Black women to breastfeed and provide them support in the community, regardless of their ability to afford those services. And so it's really important that we get the messages out to them that they can continue to breastfeed, because in the initial outbreak of the pandemic, I think people were getting a lot of mixed messages that have contributed to the myths and why people don't believe the numbers, why people weren't protecting themselves. And then one of those big myths was that you should stop breastfeeding. So we want to make sure that our community knows how important breastfeeding is during a pandemic for many reasons, right? Socioeconomical, as well as emotional. And as Dr. Campbell talked about, breastfeeding safely, clean hands, clean breasts, masks, we can continue to breastfeed our babies. And we should continue to also do skin to skin, because we realize that that is what helps build their immune system. And they need that. And so it's really important to continue to educate women, support women with breastfeeding, even if they can't come into the clinic. We do telehealth visits if need be. but just really providing that support and encouraging women when they do come in. We provide inpatient as well, or rather in clinic, as well as telehealth appointments for OB, and just trying to alleviate a lot of anxiety. And you hear a lot of women feeling very anxious and talking about how that anxiety impacts them and their pregnancy and their baby, and trying to give them tips to use to modify that anxiety a bit, so they're not internalizing that, because their babies become anxious, right? Because they are connected. So it's really important to have conversations about that, to ensure women are using good COVID precautions at home, and also to have early discussions about what would happen or what could happen if they become infected. And that's one of the things that I think we're talking about more, is to explain we're concerned about issues with clotting, with blood clots and so forth, if a woman becomes infected during pregnancy, and what that process may look like, and to begin those discussions during pregnancy as a part of their routine prenatal care, needing to do that more than waiting to see if a woman becomes infected. And I just want to add one more thing that I thought Dr. Campbell alluded to, and Dr. Thornton, is about the issues of symptomatic versus asymptomatic. And I think really in the beginning, we were not realizing that many pregnant women were asymptomatic, but they were positive. And so it's really helpful to hear those numbers provided, because there are many women who are infected with mild or no symptoms. And so in terms of keeping healthcare providers safe as well, we need to make sure that we're following the precautions, we're masking, we're wearing our face shields, frequent hand washing, and doing those things, because many of the women that we see may be infected. And actually now we need to really kind of treat everyone like they are as healthcare providers, but also to explain what we're doing to alleviate our patients' fears, because there's a lot of anxiety around the unknowns with COVID. So.
Hey, Brittany, can I just tag on to a couple of things that Dr. Moore said? So the first thing is, Dr. Moore, you mentioned the immunological benefits of breastfeeding, which of course are wonderful, and we don't have the studies yet. They're just starting to look at them, but one of the immunological benefits of breastfeeding during COVID may be that your baby gets that additional protection against COVID-19 due to breastfeeding. And it'll be a while before the studies can be done, because of course you have to study babies and moms and who has and who doesn't. But we're hoping that that bears out true for COVID-19 as it does for other vaccine preventable diseases, because if that's the case, we may have a generation of children that have been breastfed during COVID-19 that will have the antibodies and the protection, at least for a short amount of time, to protect them against it. And then the other thing is, I wanted to mention that when we say symptomatic patients, often people think of respiratory symptoms, runny nose, cough, fever. And what we found is there are all types of symptoms related to COVID-19. And so what I tend to tell people is, if you have any symptom that's unusual, you don't have it, on a usual basis, at the very least, you should contact your physician or your provider to be evaluated. And so that could be anything as simple as a stomach ache or nausea, if you're vomiting, if you notice you're just a little achy, if you got a little scratch in your throat, because unfortunately, COVID is presenting in all kinds of ways. And it is showing up to mimic other diseases. So it may be that you have some gastrointestinal discomfort, and it may be COVID. We've had patients admitted for appendicitis that happen to test positive for COVID-19. So any kind of symptom that you have that is unusual for you, at the very least, you should contact your provider to see if you need to be evaluated for COVID-19.
Thank you, ladies. And I do have some more questions about breastfeeding that we'll get to later on in the conversation. I'm a breastfeeding mom myself, and I have gotten some mixed messaging. So we'll make sure that we circle back to this in just a minute. But I want to touch on something that Dr. Moore mentioned about the misperceptions of COVID as data has changed, and it kind of feeds into people's unbelief about whether or not COVID is real and that type of thing. I know when the pandemic first started, a young person in my life told me verbatim, Black people can't get COVID-19. And now we're seeing that that myth was floating through social media, and what we're seeing is like, no, we in fact can contract the virus, and we're contracting it at disproportionate rates. I want to pivot to Georgia Ford, who works in media in being a truth teller. What are the misperceptions that you've observed as it relates to Black maternal health, and what can be done to kind of change the narrative?
Yeah, absolutely. Brittany, thank you so much. And thank you to all the frontline workers who have been working tirelessly to keep pregnant women safe throughout this entire pandemic. You know, I think that mainstream media is not conveying these stories enough. And so in thinking of changing the narrative, I think that we need to amplify the narrative first and foremost. But a lot of the work that I have done surrounding Black maternal health has been shifting policy for time off and shifting the narrative in terms of the way that pregnancy is even, spoken about in legislation. And so that conveys as well through the media. Right now, we know that legally pregnancy is usually referred to in laws as either a medical condition or it's conveyed as a disability. And so you'll see that language, that narrative show up in media as well because of the way that the language is in the law. And so the work that I've been doing is to shift the narrative and have pregnancy and birthing looked at as a human rights issue as opposed to a medical issue or a disability. Even though it affects women's bodies, this is a family issue. And under the Universal Declaration of Human Rights, which was created by the United Nations, Article 16 says that it is a human right to have a family. And so I think that even in terms of COVID, if we can look at the intersection of pregnancy being a human right, I think then it elevates from being just an exclusive issue that impacts women to something that impacts our humanity. And so I do think that, if people approach it as a human rights issue, even the media may be prone to look at it from a broader scope as well. And we often see, if there is a story like Amber Isaac, she was tweeting, actually, one of her last tweets was about the concerns that she had with the hospital where she was scheduled to give birth. And a few days later, she actually died and was not able to go home with her husband and her new baby. And so, that's a story that caught headlines briefly, but, it comes and goes in waves depending on specific stories and if they're able to catch the attention of national news. So I think that we're working, community storytellers, independent media outlets are really committed to these stories and amplifying these stories so that the broader community realizes how big of an issue this really is.
Absolutely. And can you give us the name of the some of the productions that you've done so far where people can learn more about this?
Yeah, absolutely. The biggest piece that I've worked on so far is the Pregnancy Human Rights Act. And so there's not really a central place for that, but you can visit 12weeksforlife.com to learn more about that bill. And then I'm in the process of launching a series called Cost of Life, which will also focus on the experiences that Black women have in giving birth. And unfortunately, the stories of those who are survived by women who don't make it through.
Thank you. Those stories are incredibly devastating, but they're important, an important part of our narrative that should not be erased when we talk about Black maternal health and Black women in their transition into motherhood, and how it can be a very scary, life-threatening experience when it should be one of the most joyful and supported experiences of our lifetime. And so it's my hope that we can start to be honest about the experiences that Black women have navigating the medical system, and then to make some real change to shift the narrative and also to shift our experience. Keeping in that same lane of shifting our experience and being honest about our history, I want to ask Dr. Zeke, who is supporting the vaccine trials here in the state of Minnesota. I asked my Facebook friends, I meant to tell you this morning, I asked my Facebook friends, what do you think about the vaccine trials for COVID-19? There are 2 presidents of HBCUs down south that have committed to being a part of the trials, and they're encouraging their students to do the same. Now, I'm not sure if it's because it's HBCU presidents or people just knowing their history, but a lot of people felt like this felt like the Tuskegee experiments all over again. And they were feeling very uncomfortable about the idea of participating in a vaccine trial for COVID-19. You know that, and you've actually educated me also, it's actually incredibly important for Black people to participate. So can you tell us why we should continue, consider participating, and how to move forward, also recognizing that there is a large distrust between our community and the medical system at large?
Yeah, thank you, first of all, Brittany, the other panelists, Alf, and everyone supporting this forum for having me. I feel very honored and privileged to be a part of this panel of primarily women talking about maternal health as a man, so I'll do my best to represent you all well. But as it pertains to both engagement in healthcare and clinical research, I mean, you touched on a couple of points there, Brittany. The Tuskegee experiment is probably the most famous instance where, you know, Tuskegee airmen were enrolled in a study to look at syphilis treatments. And ultimately, once penicillin became the accepted standard to treat syphilis, they were actually not given it. And that was a huge, obviously, ethical error and something now that historically we look back on. And that's one of the reasons why there still is very much appropriate trust and distrust and mistrust in the healthcare community and healthcare research. There are a couple of other pretty notable examples, but I don't know if we need to go into those too much. I'm happy to if you'd like me to. But what we've also seen is kind of an opposite problem too. And this is something we're observing now in medicine and medical education, what they call race-based medicine. There's very much a focus on pointing out that race is not a biological construct, it's actually a social construct. And so there were some studies that have been done in the past looking at things like, for example, kidney function or lung function. And so now when you get certain clinical tests looking at kidney function, it actually calculates that differently based on if you're Black. If you get a lung function test spirometry, it calculates the results of how it's interpreted differently if you're Black. And it turns out all the data that those were based on were actually in primarily white populations and in very small populations of color. And so the extrapolations or sort of the expansion of how they took that knowledge and applied it to communities of color is actually pretty inaccurate. And so that's something that we're working on now in medicine and medical education to totally do away with if we can. And so as it pertains to engagement in a trial of a vaccine like this, I would make the argument, sure, yes, we don't want to participate in something where people are picking out, you know, persons of color individually and trying to experiment on them. And this is not the case here. And in fact, very much one of the reasons I felt it was important to be a researcher in the site study here in Minnesota was to, of course, be able to mitigate anything of concern if it were to arise, which again, I haven't seen that so far. So then to address the other issue of making sure we're well represented, you know, if we follow these lines of mistrust and distrust and don't participate, then we won't know how these vaccines respond in, you know, the Black community, and ultimately may not be able to find out until it's out in the wild and people are just getting it, and we didn't know certain things that were going to happen or that we might want to be concerned about in advance. And so I'd say making sure that we're adequately represented is absolutely the reason to participate. And when people ask me, well, gee, what can I do about the pandemic? I mean, aside from, please stay at home, try to ignore pandemic fatigue and do your best to stop spread of the disease, I would say engagement in trials like this are certainly one way to strongly participate.
So there's the cultural history in the reservation, given situations like what happened at Tuskegee. But then there's also just the risk of being introduced to a new vaccine. What have you found out so far? How are people reacting? Where are we at within the trial? Because I think, there are multiple questions that people have. So I'll give you some space to help people understand just what's happening within the trial.
Yeah, thanks so much. And at the risk of being a little long-winded and scientific, I'm going to do my best to to try to break it down here. So clinical trials generally are broken into 4 phases. So a phase 1 trial is just, hey, how does this drug or vaccine even work? Phase 2 is, okay, what's the right dose that we need to, phase 0 is how does it work? Phase 1 is how does the drug even work? Phase 2 is looking at safety and efficacy just in people who they're giving this drug or this vaccine. And where we are now, at least with the trial specifically that's going on here in Minnesota, and by the way, this is actually a worldwide trial for which we're one of 100 sites. This just happens to be the only one available in Minnesota, is a phase 3 trial where you look at this vaccine in comparison to, for example, a placebo. So, giving somebody, let's say, an injection of saline, basically salt water, nothing that's expected to do anything. And so usually a phase 3 trial is comparing either against sort of a placebo or nothing, or against, whatever the normal standard of care is if they're trying a drug, for example. As it pertains to, sorry, I'm trying to remember all the layers of your question. As it pertains to looking at efficacy and adverse effects, so there are different types of vaccines that exist, how they work. Probably the 2 most common are what would be called live attenuated vaccines. So that's where they take a live part of a virus or a bacteria, but it's attenuated as in it's actually it's a more weak form of it, and then try to induce an immune response from that. The good news is this vaccine is not that. Those vaccines, a live attenuated vaccine actually does have the very rare potential to cause, a milder form of disease than what you would normally expect, or cause some type of severe adverse reaction, especially in somebody who, maybe has problems with their immune system already, somebody who's, has HIV or who has had a transplant, isn't on drugs that, kind of dampen the immune system. But the other very common form of vaccines are what are sort of inactive forms of the virus, and that's what this particular COVID vaccine is. So first of all, it would not be expected to give people COVID in any way whatsoever. Scientifically, it's basically just not possible. However, that doesn't mean that there's no risk of harm. So in the phase 1/2 trials that were done, and these results were published in July in a pretty big medical journal, there were some adverse effects, but they were all fairly minor. People had, a little bit of headache, a little bit of fever. They had pain, right at the site where they got the vaccine. That's all really common. And most of those things were treated well with Tylenol. Now, part of phase 2 and phase 3 trials are to look for adverse events. It turns out right now, this particular trial, well, it was on hold everywhere as of a couple weeks ago because someone did have a severe event in the United Kingdom, and they weren't sure whether it was related to this vaccine. Now, on the one hand, I could see how people would say, oh my gosh, if bad stuff is happening, I don't want to do this. But I would say, well, you should actually maybe look at it the other way and be reassured that our processes are safe enough that where if something bad does happen, we immediately stop and take a look at it and figure out what's going on. So it was a very unusual neurologic condition that came up in response to this, and somebody who had a very complex medical history. And right now, the UK has already restarted I don't believe they did feel that this was related to the vaccine necessarily. However, it has not restarted here in the United States because the FDA is still finishing their investigation, and I think it'll probably start maybe next week. It's not 100% certain yet. So the status of the trial here is we did start a few weeks ago, and it started enrolling people, but very quickly it came to a halt because of this stop, but it's expected to restart. And so What I will say is we are still looking to engage more of the Black and African American community, as well as other communities of color, as well as other communities that may be more at risk because of other medical conditions, or people who may be more at risk because of different occupations. And I don't know that we've got the representation there yet, and we're really trying to set up a pipeline. So if, let's say, for example, Alf said, hey, Zeke, you know, we got all these people who are actually really interested, I would have a way to get them in, and so that they wouldn't, you know, be put at the bottom of the list. And, you know, we're only doing this in a very narrow segment of the population. I hope that answered most of your questions there, Brittany.
It did. You answered all of them. And I'm wondering, what else do you think needs to be done to help bridge the distrust and apprehension that people in the community may have as it relates to not just the COVID-19 vaccine, but vaccines and just encounters with the medical system as a whole?
Yeah, well, I mean, I first of all think it's the responsibility of folks like myself who, you know, are trained in this field and work in this field every day to get out there and try to rebuild some of that trust and say, look, there are people like you who are out there doing this work and who believe in this. But I think part of our job is also to spread that education. So, you know, people can tell their friends, they can tell their mom, they can tell their kids, you know, oh, you know what, maybe there isn't as much to be concerned about as we want. Now, with that being said, I don't want anyone to walk into any healthcare environment and say, okay, I just have to trust everything everybody's gonna say. No, not at all. But the one thing I tell all patients, you know, white, black, whatever, is you have to be an advocate for yourself. And, you know, in getting prepared for this talk, I started looking through more of the contemporary research, and this has been going on for probably 10 or 20 years now, showing that, you know, for example, Black people are less likely to be believed about symptoms, they're less likely to be believed about pain, they're less likely to receive some of the standard treatments for a variety of things. And honestly, I think I just need to prepackage that on a little card and give it to people to take to the doctor. So then when they feel like that's happening, they can say, hey, by the way, I don't know if you're familiar, doctor, with all this contemporary research that shows you might be making a mistake here, because I want you to believe me in my experience. You know, one thing I tell patients when they come to clinic is, look, the first principle of medical ethics is patient autonomy, meaning you get to choose what's right for you. I am just an information source. If you want to take that information and do everything I say, I'm totally cool with that. You want to take the information I say and do nothing, I'm cool with that too. You want to take some and leave some, that's fine as well. It goes so far, I'd say, look, if you want to fire me and help, and I can help you find, you know, maybe who the right person is for you, I'm okay with that also. And I want patients to be able to know that those are options that they have to exercise when they are at the doctor. We can't force you to do anything, and we shouldn't force you to do anything. And if you feel like that's happening, you have to be able to speak up for yourself and say, you know what, I'm not comfortable with this. Can you recommend somewhere else I can go where they might be hearing exactly what I'm trying to tell them, or might be able to better meet the needs that I feel like I want met?
Yeah, it's definitely a process, and I appreciate your willingness to, one, not just talk on this panel, but to have very transparent conversations with your patients. And I think it's those experiences between the patient and the physician, and there being authenticity and trust that can really go a long way in the way in which we feel safe and cared for, which ultimately should be the minimum, you know. And unfortunately, our experience, not just historically, but in present day time, especially as people of color and especially as Black women, is feeling like we're not heard and we're not listened to. I want to pivot to Dr. Rwanda Campbell, who is an OBGYN and who has worked with a lot of women during the pandemic and before that as well. We know that the history of obstetrics and gynecology has been incredibly harmful to Black women, and the study itself being founded on experimentation of enslaved Black women. And so being a Black woman yourself and caring for other Black patients, I'm wondering, how do you hold the truth of the harmful history while also shifting the experience for our Black women in real time?
Great, thank you for that. Primarily, when I meet with my patients, I primarily tell them I do this to empower women. That is my role. I feel like that's my place to be here during this time, is to empower women. When I mean empower them by knowledge. So granted, yes, the unfortunate storied history of gynecology in which Dr. Sims, experimented on enslaved women, doing all these quote, quote, routine procedures and using that data to support some of the things that we do every day. So I think now what has happened to us women of color within our societies, professional societies, is that we now have a voice in those societies now. We now have a voice individually when I interact with medical students or residents, is to share with them, yes, we call this the Sims Retractor, but guess what? We're working on changing that name to begin some of the taking away some of that bad history is just by renaming, as well as talking about it and saying up front, gosh, do you guys know how we got here? Or this is how we're going to get there. But I think the biggest component really is empowering our patients, empowering women with knowledge about their bodies and then where they are, so that we can move the specialty forward. And in the caveat what Dr. Zeke was saying, I just want us all to know that yes, we are having these vaccine trials, but unfortunately, pregnant women are not part of these vaccine trials. So I share that to say, even though this is hyping to me like, oh my gosh, waiting for the vaccine, for pregnant women, you're not going to be candidates for it. Because right now they are not even part of the studies. So I granted when it does come out, they're not going to be candidates for the vaccine. So again, back to what we're saying, when it's still going to come back to women being empowered, with those 3 W's, washing your hands, wearing your mask, watching your distance. That's even going to be key to our pregnant women, those women who are thinking about becoming pregnant, even to their family members as well. So I'm just really sharing it, just like, it's still going to come back to what we're doing. It's not going to be a fail-safe for our pregnant moms. And as we talked about, the whole issue with maternal, because of the maternal death rate, the mortality is so big now, because we are now, we're now heavier. We're obese. We already become pregnant, either having high blood pressure, having asthma. So therefore, that your pregnancy is a high risk, and then COVID again makes these women more susceptible to it. So I can only see, unfortunately, unless we really begin this strong empowering our patients or empowering women with this education on things that they can do themselves, then in turn, if not, we're going to see those numbers probably potentially increase, perpetuated or attenuated by our unfortunate COVID experience that we're having.
Dr. Campbell, I just wanted to respond a little bit. I think you brought up some important points that I think I failed to mention, which is, yes, the current trial is not including pregnant women. And in fact, a pregnancy test is part of the initial screening for women who are interested in participating. But back to what I was saying about inactive vaccines, those generally still are very much recommended for women during pregnancy, for example, such as the flu vaccine. And so I was wondering if you could comment a little bit on that vaccination during pregnancy, Dr. Campbell. Thank you.
Absolutely. Thank you. Yes, we are advocating that women definitely should get the flu vaccine. And I would only say, and mom's like, oh my gosh, I always get the flu. I said, no, I've seen, because flu, when you're pregnant, you're somewhat immunosuppressed, meaning that you can sometimes be more susceptible to diseases. So by you getting the flu vaccine, you protect yourself, because the sickest patients I've taken care of before COVID actually have been those who've had just the flu. So I've had patients who've had had the flu, didn't get the vaccine, and she's on a respirator in the ICU. So it seems to when we are pregnant, those things we get sicker. And so we also recommend too that women get vaccinated for pertussis. We did around between week 28 and 36, and that primarily because pertussis, or you probably heard whooping cough, again, something that potentially can affect the newborn, because the babies don't get their own vaccination until they're about 2 months old. So when you're immunized during your pregnancy, there are some passive antibodies that go to the baby to protect the baby. And then we also, again, make sure though that everyone that's going to be around that baby also is immunized against pertussis as well. So the big thing is, so when those babies go home, they need to be in a cocoon of safety. So meaning that everyone who's going to be involved with their baby gets a flu vaccine, because they can't get their first flu vaccine until they're 6 months old. And again, as well as also to be vaccinated against pertussis. Because again, as we talked about too, our babies of color still more likely to die, say, than babies of non-color. So again, we just want to optimize when that baby goes home being breastfed, when that baby goes home, that everyone in the home is has a flu vaccine vaccinated, as well as pertussis vaccinated. So just optimizing safety for that baby.
For sure. And I know Dr. Zeke wanted to comment on the cocoon of safety. Dr. Zeke, take it away.
Thank you. Yeah, I really appreciate Dr. Campbell's comments. I think she's hitting all the high points, and it makes me think of things I'm trying to say too. So this cocoon of safety she mentioned, that's what we would call in public health herd immunity. So, so many people out there actually cannot get certain vaccines, whether it's because of pregnancy, and if it's a live vaccine, for example, or if it's because, somebody has a condition like HIV or another condition that affects the immune system. And so those people really are relying on folks like us, that is folks who can get the vaccine, to be protected and not be spreading the disease to them. And so to speak to Dr. Campbell's point specifically about, newborns definitely do not have a fully developed immune system. That's one of the reasons that breastfeeding is so important, as some of our panelists were talking about here. But also that's another reason why vaccination is so important as well. I mean, when I talk about the flu vaccine generally, it's really, we need to be protecting ourselves so that we protect our older populations who are going to be more at risk, when you're visiting mom and dad, grandma and grandpa, and as well as the newborns, all of whom aren't going to have as strong of immune systems and not as strong of an immune response, and some of whom may not even be able to get the vaccine. So I just wanted to sort of bring that out there about herd immunity, and one of the important reasons that community vaccination is very important.
So Brittany, I just want to say now, now, please mind you, when patients come to us and we have these conversations, again, it's about empowerment, empowering them with the information. So I will still care for a patient who says, I don't want a flu vaccine. I also care for a patient who says, I don't want a Tdap. I get on, and so we have the discussion. So as long as I know that as her OBGYN taking care of her, I provide her with that information, she now has the autonomy to make that decision, that's okay. And I still treat her the same way when she comes in, when she comes and sees me, and I see her in the hospital. So again, you can have that conversation with your provider. We provide you with the information, you accept or choose not to, but I'm still going to care and respect you as an individual, to care for you.
Yeah, I think that's a wonderful point about, individualizing care. I mean, I think as a patient, the one thing you can walk in the door and say is, hey doc, here's what my goals are. So then they know what you're trying to achieve. Just the same way Dr. Campbell says, I don't really treat pregnant women very often, but certainly if somebody comes in and says, well, I want to treat my blood pressure, but I don't want to stop smoking, or vice versa. I want to stop smoking, but I don't want to treat my blood pressure. That's okay. It's not my job to judge you on what your health choices are. And similarly, I don't want anyone to judge me on the health choices I make for myself.
The two of you bring up a really good point about denying vaccines if that's your choice. If you just say, or any type of medical intervention to say, you know what, I don't want to get the flu shot. I don't want to get the Tdap. I don't want to get this. I don't want to get that. And you will still receive the same care. The two of you physicians on this call are saying, you're still going to treat the patient just the same and respect their wishes and come up with a plan to support them. However, what we know is that when you are pregnant and when you are in labor, your advocacy of self doesn't always go the way that it should. You may have a birth plan which says that I don't want any type of medical intervention. I don't want a C-section. I don't want to deal with forceps or any of those things. I don't want Pitocin. And then all of a sudden a doctor or a nurse comes in and says, well, you know what? Your labor is just not progressing as much as we thought it should. We need to give you some Pitocin so that we can speed up your labor and really get those contractions going. And it can be very disempowering for a woman to feel pressured as if her body is not doing what it was created to do, as if the birth plan that she had looked forward to for those 10 months suddenly can't happen the way that she had envisioned it. And what ends up happening is mothers leave the birthing ward, the maternity ward, feeling disempowered, feeling traumatized because they're felt and pressured to participate in medical interventions. And they're a lot of times told, it's dangerous for you, it's dangerous for the baby, we have to do that. And what they find out after the fact in doing research about medical intervention and just the disparities, especially for women of color and Black women in the medical system, is that a lot of times those procedures weren't actually as necessary in the first place. And so I want to ask Dr. Moore, as it relates to birthing and women having autonomy over their bodies, Black women often don't have that experience. So what can we do so that they are treated with care and dignity, even if they have a particular birthing outcome that's not in alignment with what their physician suggests? I'll take you off mute here. See if I can help out.
You brought up a very, what I would call a hot topic in many ways. And so there's, and I'm interested in hearing some of the other participants' response, but I'm just going to tell you how I approach it in my practice. Is I no longer talk about birth plan. I think birth plan gives the woman false hopes in a way, because there are times when things are done for medical reasons, and it can be very disempowering for women because they're wrapped into this issue of control around birth. And so I think we set them up as providers by talking about birth plans to begin with, assuming that we have all this control over what happens in pregnancy and birth. And, you know, pregnancy is kind of one of those miraculous times when we get to participate in a miracle, and we don't always have control over it. So I feel like having a discussion around the reality of pregnancy and birth up front is really important, and to talk about wishes, what we wish we'd like to see, and to have a real talk conversation that things may not go that way for many reasons. But we attempt to honor people's desires. I also like to have a conversation with their support persons. There's a little tool that I give around consent and decision making that they can take home, that their partners and families can use to help them make decisions as well during challenging times in the hospital, where people of color inadvertently just feel disempowered when they walk through the doors because they're surrounded by a majority of people who don't look like them. It's kind of a power imbalance to begin with the physician and quote unquote patient or client. So people just kind of naturally feel disempowered and unsafe in those situations. But I think we need to have conversations with women up front about the expectations of pregnancy and childbirth, to have real conversations that all pregnancies do not turn out well. It's our desire, but we often don't talk about that up front. And also to have real conversations about birth wishes and how those may be changed, and not plans, because plans seem to be very cemented in stone for people. And it really becomes, women lose their joy in their pregnancy and childbirth experience if it doesn't go click, click, click exactly to the plan. We have to admit, we've kind of had a cultural shift in this country where people really feel very need to be in control. It kind of reminds me, it started to me when I saw it in my practice, when Palm Pilots and things came out, when we could schedule appointments and things electronically, and people really wanted to kind of have their birth at particular times around events in their lives, starting new jobs, starting new businesses, traveling, going to their family reunion, all of these kinds of things that really aren't real, and sometimes even not even safe. So just having some conversations about the reality and the around childbirth, and also that sometimes we just, you know, it's the only time you get to participate in a miracle, and sometimes you don't have a control over how that turns out, so that people aren't so disappointed when they can't control everything. There's just false perception of the ability to control things in our world. So
Absolutely.
That's my approach. I don't know, Dr. Campbell, I'd be interested in hearing from you.
So I think what has happened to us professionally is that usually the challenge is now is at one time women would come in and see the same provider in her pregnancy,
Yes.
and then that provider would be there on the other end delivering her. But now, because of provider availability and actually burnout, practice have somewhat changed, where you primarily will see your provider in your office, But then when you come to the hospital, it's probably the physician who's on call for the group that day cares for you, so that your doctor hopefully can be home, he or she getting rested. So the job I have now at Central Care, I'm in St. Cloud, I am what they call an OB hospitalist. So I'm the one who's there for 24 hours a day. And my goal is when I'm there to take care of the high-risk pregnant women, even some women who are not high risk, but deliver those patients within my 24-hour shift. So I'm the one who's there to keep them safe. So how I approach it now, usually it's like patients come and say, hey, what is the goal for today? The goal is happy mom, happy baby. And so with that being the goal, and this we go through the P's of labor, you know, the patient, the parent, the passenger, the pelvis, and the power. And I say, this is how we're going to make those decisions today. So that as we come in, as we're going to go 1, 2, 3, so we can have a discussion. Now, I always joke and say, if I walk in the room and I see this, there's going to be no discussion, because remember, the goal is happy mom, happy baby. We're working on now, it has to begin in the office, as Dr. Moore said, it has to begin in the office as well. So that won't be the first time that they hear that, you know, what what their wishes are. So we are, as a specialty, are having to work together with, as far as trying to get the message right, to begin the message in the office about what the expectations are when they actually come to the hospital. So we talked about the whole issue with COVID and how COVID has affected this whole birth process. So as you probably remember, initially when the pandemic occurred, we said, oh gosh, no one can come to the hospital, because at that time, again, we didn't know who had COVID. We did not have COVID. So we, even during the height of the pandemic, we would at least let one family member come in with the patient, you know, if that person, you know, was asymptomatic and passed all the screening. So even now, with the somewhat of a let up a little bit, the patients now are at least offered, they can have their labor support, either a dual who comes with them, along with just one family member. But yet again, with our families of color, you know, they're used to what the mother's there, you know, the husband's there. So we've had to some places we've had to kind of say, no, really not the case. So now we're trying things like, okay, let's put them on FaceTime. You know, we now use iPads and technology that maybe they have the family kind of like in the room, you know, they're not physically there, but allow these patients now an opportunity, you know, to garner their support and everything. But I think it just kind of goes back to, we just really have to pivot always, so the women can feel empowered with their process of saying, gosh, what is the goal here? And how are we going to reach that goal? And that's really what the thing is. You kind of have to refocus, as Dr. Moore was saying, kind of refocus, you know, is that, because I know when I say someone has a plan, I'm like, oh my goodness, she's going to get it all. Everything she says she doesn't want, she's going to get, you know. But again, what is the goal? And so as your doctor, care for these 24 hours, my goal is happy mom, happy baby. And we're going to have a discussion as we go along, what the options are, so that again, you can feel somewhat empowered in your decisions of the goal of having a happy mom, happy baby.
Can I also have a few more comments? One, I appreciate Dr. Campbell's comments, and again, reminding us to, as providers, to have these conversations, start prenatally. We have them for many months in clinic prior to that process of birth, to get people educated, to make sure they have support systems in place. One of those pieces is that I think is really important is childbirth education as well. I know childbirth education is not always available at many hospitals in the way that it used to be. We at North Point offer childbirth education. We also have the iChirp program that provides support to African American women during pregnancy and in the postpartum period. That's a program that's available. And we also want to encourage women to get labor support if they do not have a support person, such as doulas are available in the community to provide education and support during pregnancy and childbirth. So good support and good education. And from my experience, women who educate themselves, who come to childbirth education classes, have a very different experience from people who go in just cold. We encourage people to read and empower themselves in their knowledge, and to have discussions along the way about what they'd like to see for comfort measures and those kinds of things. But when women have done some work on their own, around childbirth education and some reading, I think they're less apt to feel disempowered in the birthing process. So as well as those who have support do better. And we know the research is out there around good support. So it's important for women to engage themselves in that way as well, because those are the things that they can, again, control to help have a better birth outcome and feel less disempowered in the process.
Thank you. And that's incredibly important for women to know that there are resources that are available, that doulas can, in fact, be in the room with them in addition to the birthing partner. And, you know, not everything about the pandemic and the way that we're having to shift is a negative thing. I know I didn't give birth during the pandemic, but, you know, 2 years ago, and it was great to have my family on FaceTime and not in the room. You know, these are some things that we can be thankful for and that we can actually control, and managing expectations certainly is one of those things. And also we know that it's the bias of the practitioners that is the primary cause of Black maternal mortality and morbidity, as well as Black infant mortality and morbidity. And so I also wonder about systems change. We empower our mothers, we educate our mothers, we manage expectations, but what needs to happen, I'm wondering, either at a policy level, statewide, federally, and within our medical institutions, so that there isn't an incentive or a benefit to pushing Pitocin and cesarean sections and other forms of medical intervention, and allowing a mother to really choose whether or not she wants to engage with those things. Can any of the physicians or anybody, you know, we've got mothers on the call as well.
So
can somebody speak to that point?
Yeah. So I think the challenge, it has to go back to, again, Brittany, what is the goal? So I think what is the goal when we're interacting with the patient? And so yes, and I know there is a cadre of information out there as far as, you know, Pitocin and C-sections, but I'm just telling you, when we walk in at what is the goal of what is the goal, then we can really have those discussions. Then it's not perceived that I'm pushing something onto a patient or recommend they have a C-section because it's gone long. And so I think what we are learning, because I'm actually also attending one of my national organization meetings this week, and we're talking about this, is that we really have to work as professionals, that when we educate and talk to our patients, that we're saying we're not just because I said so, but because pushing it back, what is the goal? And so, yes, there are several words out there about, these different modalities or interventions that someone looking back may say, I shouldn't have had it. But I tell you, when it's in the thick of things that are going on and, someone's been there for 72 hours and about to get infected and her labor is still stalled, I mean, it's a whole different story. And so it just, again, as Dr. Moore was saying, we have to professional to do better education of educating our clients or our patients up front through childbirth education, separate classes, as well as when they're in the office. So when they come to the hospital or come to the birth center, that those things have been discussed. And it's like, oh yeah. So if a mother has gone through childbirth education, then they've learned probably, when this happens, these are things we usually recommend. Or if this happens, this is what you usually recommend. So that they don't hear about Pitocin the first time, when they see me on that day of labor and delivery, or they don't hear about a C-section or why we would do a C-section, on those day and times. So totally tuning what Dr. Moore was saying. We have to go back. It has to be done upfront, the education, so that those who come in say, oh yeah, I read about that. Yeah, I had yeah. Oh, because sometimes I ask, well, I haven't changed my cervix, so do we get the Pitocin soon? You're like, oh, it's someone who went through childbirth education, where sometimes the patient even says, I should be thinking about this now because this is what's going on. So it really comes back to the education. And so policy changing, doggone, to get pregnant, you have to have childbirth education. You know what I mean? That as far as that requirement goes.
For sure.
And Britt, to piggyback on what she was saying in terms of policy change and education, from a systems level, it's going to take a lot of work, but we have to start with calling it what it is. And so a lot of organizations are really moving more into the diversity and inclusion space, which is good, but it's a lot of work. So it has to be done. And so we start by, one, having conversations like this, but also calling it what it is. So when you see implicit bias or you experience it, call it out, call it what it is. We have to start holding our providers accountable for treating us differently, and we have to tell our stories. And so, for instance, sharing our stories with people like Georgia, who can get it out there for more people to hear our stories, we have to tell these stories so that people know it exists. When Serena Williams came out and shared her story of almost dying during childbirth, people were aghast. Oh my God, I can't believe this happened. And all of us were going, well, this happens to us all the time. But had she not shared her story, it would not have gotten the national attention it got. And so now people are actually listening and trying to hear what we've been saying for decades. And so I think from a systems standpoint, it's going to take a lot of work. Dr. Campbell and Dr. Moore alluded to it. We start with educating ourselves so that we can hold our providers accountable. But then from a systems point, systems have to work to identify implicit bias, call it by its name, hold people accountable, and then start making changes so that that doesn't exist anymore for patients that are continuing to come through the system.
I'm really glad that you said that, because I feel like 9 times out of 10, the stories that I have heard were not experiences that mothers had with Black doctors, Black physicians, Black nurses. And so I know that we have a lot of really experienced and knowledgeable Black doctors on the call today, but the issue is not our Black physicians. It's the physicians who don't look like us, who don't believe us, and who don't listen to us when we're advocating to ourselves. And so those are the stories that I'm more familiar with that kind of align to what Brittany was talking about in terms of women going in to have a baby and leaving out and feeling really disempowered. And so I think, Adrienne, to your point, the implicit bias is really something that needs to be addressed. And as a mother of 3, in my own life experience, I think when I had challenges in giving birth, it was always in situations where I was dealing with a white doctor. And so having to be an advocate for yourself and speak up for yourself, and ultimately trusting that, yes, if you do the knowledge on the front end, then you should be equipped and prepared to speak to what you're experiencing in your body, and your doctor should trust you. And so, but we know that's not always the case. And so to Brittany's question, to tie it back into the question about policy, I think that on the state level here in Minnesota, we are seeing some representatives like Ruth Richardson and Representative Rena Moran, who are really on the front lines and really advocating for changes as it pertains to laws with, Black maternal health issues. And so I think we need to remember them and support them, as they're doing that work. Because even once you get a policy passed through the House of Representatives, then it has to go to the Senate. And that's kind of where a lot of bills get hung up. And so while we're, doing the research on the front end before we're going in to give birth, I think community also needs to be doing its research on the, politicians who are pushing for policy change that will ultimately impact birthing centers and birthing rooms and make them more equitable for mothers of color.
I appreciate that, Georgia. I'd also like to add that I'm looking at our educational system in terms of how providers are educated. I also think that we need more Black midwives. I know I'm a Black midwife. I'm going to be, so I feel like we need more Black midwives in this state, and that their education needs to be reformed as well to include the history of Black midwives in their training, which it was not when I was educated. Had no idea the strong and incredible history of Black midwives in this country. So I think that's important as well. How we educate medical students is really important. Sometimes it almost feels as we still continue to practice on communities of color with in terms of, when they do various rotations, but in the curriculum, are they being educated from historical perspective on the population that they're coming out to train on. I'm not sure that's being done, and I'm sure you other Dr. McKinney and Thornton and Campbell can speak to that, but I think how we educate providers is important, and that needs to be done as well. And also policy change around practice, nurse midwives being able to practice and be reimbursed to the full scope of their capabilities as well. All of those things impact the care and need to be changed through public policy as well as through the reimbursement system in the healthcare system.
Absolutely. I want to acknowledge our time and give everyone a chance to give their final thoughts on where we're at as it relates to being in a pandemic. There are vaccine trials that are happening. There is very real medical distrust from a historical perspective, as well as our everyday perspective, especially as Black mothers. And there's a very real Black infant and maternal mortality and morbidity disparity that we have to mitigate. So I know we're not going to solve everything on this phone call tonight, but I'm curious from all of you, either where do we go next, or what are your final thoughts as it relates to everything we've discussed today? And I'll start with Dr. McKinney.
Thank you so much. To be honest, I thought everyone just did a great job of addressing some of the systemic issues. I mean, I'll double down on what everyone else said: education, education, education. As it pertains to our patients, you know, in my fantasy world, Black patients would be the most educated. And when they come in and they feel like their clinicians aren't doing what they need or want, they can come at them with a high degree of education and say, wait a second, I don't think that's what the standard of care is for this. But similarly to what Dr. Moore just said, you know, we are seeing changes now in medical education, addressing some of these historical contexts. I still don't think it's enough, and I still think we need to go a lot further. But looking at issues of health equity, that needs to happen at the, you know, from day one, even in pre-medicine, you know, even, I mean, right now, I would say, you know, we need to get back to having health classes in elementary, middle school, high school, so people know what to expect when they go to the doctor and how to advocate for themselves. As far as systemic changes go, you know, some of the literature that talks about, you know, pain not being as recognized in Black people says, look, you know, one way to address this is to make sure that people are adhering to, you know, standardized guidelines. Are you doing the same thing for this Black patient that you'd have done for every other patient? You know, things like that. I mean, there is some implicit bias in clinical algorithms, and that's a whole nother issue, but I think at least making sure that we're doing the same thing for everybody, and also still individualizing it to a patient's goals is a big thing. And then last but not least, probably another point that Dr. Moore mentioned about, you know, reimbursement. You know, right now medicine is moving to what they call value-based care. Well, look, if we want to provide better care, we need to start holding people accountable in that way too. And so at the end of the day, it doesn't matter if you want to take a carrot or a stick approach. You know, whatever hospital systems or clinics are having greater disparities, reimburse them at lower rates. Or inversely, if you're having a less degree of disparities and you're more equitable, you know, reimburse them at higher rates. I will assure you, you do that to health systems, and they will change their tune really quick, at the risk of being ultra controversial, but I believe that in my heart. Everyone follows the money. So thank you for having me today.
They absolutely follow the money, and thank you for naming that. I want to go next to Dr. Campbell. What are your final thoughts?
My final thoughts is that as we move to this new area where we're more likely going to have increase in our numbers, I just cannot stress the importance of, for my moms carrying these babies, that if, again, as Dr. Moore said, if anything's different about your symptoms, please come in and be evaluated, to be tested for COVID. And also too, just keeping your family safe, safe during this time, you know, of the 3 W's, because I am just, I am concerned about, you know, what the next few months are going to bring to us. But I'm grateful, though, that at least we talked about before, that at least we are now able to screen our mothers before they come to the hospital. So at least now they know, and then I know, so we can, you know, we can care for them. But just grateful that I could be part of this forum. Would love to come back any other time, and also that I can meet my other colleagues here. Maybe we can be part of that message as far as making some of those policy changes. And so I'm certainly all in, even though I live, you know, north of the cities, but I'm certainly all in to being a part of things outside of this forum so we can make some of those policy changes to take care of our patients of color. So thank you. Just grateful for the time together today.
Thank you. Thank you for your time. We most definitely appreciate it. And I want to name that the work of shifting policy and sharing narratives and being a part of the solution is not going to be done by one person, but a collective effort by the community, whether you are a mom to be or hope to be a mom, or you're a physician or a concerned member of community. Everyone can be going and calling your local politicians and letting them know that we know we're in a pandemic. And we also know that there were certain bills that were presented on the floor that related to Black maternal health and that supported Black women and other mothers getting extended maternity leave, and they were denied because of COVID. And this is the time. There's not a more appropriate time for us to educate and to empower our Black mothers in their birthing experience. And so I do hope that those who are watching also feel compelled to join the fight in advocating for Black moms. I'll pivot to another Black mom right now, Miss Georgia Ford, and say, where do we go from here? How can people support the work of Black maternal health?
Absolutely. And thank you to all the frontline workers who are on the call, doctors who, have been in this fight with mothers through the entire pandemic. We really value your guys' dedication. My perspective is obviously different working in media, but, I want to encourage folks to own their narrative. We can control what we put out on our social media. We can control the feedback that we give to the hospitals. We can control, what we say when we show up to city council hearings. And so own your narrative and amplify your own experience. I think that those are tools that we have access to that cost us nothing, and that can really be the center of a lot of change. Stories are so powerful when it comes to shifting processes in organizations like hospitals and clinics. And stories can be very, very powerful in shifting the minds and the hearts of politicians who ultimately determine what policies are changed. And so be empowered in even if your negative experience in a hospital or your negative experience through this pandemic can bring about something positive like change for other mothers, or if you have a daughter, change for them in the future. And so I want to leave people just, with that hope that regardless of what your experience is, own your own narrative. And I think that once we start to do that as a community, regardless of whether or not our stories are showing up in mainstream media, they'll be showing up in our community. And even the professionals who work in the medical field, knowing that they're able to see and access these stories, I think will equip them better to advocate for, more equitable circumstances for mothers of color. And so the other piece that I want to leave people with is being a person who has used my own narrative to try to shift policy. Showing up at the Capitol and speaking on maternity leave may not be as exciting as going out to a protest at the 3rd precinct, but it is just as important that we are showing up. There's other policies and bills that are out there. And oftentimes, if you ever, tune into those hearings, there's not a lot of people in those spaces. And so it's really, really important that we make ourselves knowledgeable about the process to change laws. And that we're showing up, and Brittany, as you mentioned, calling your city councilor or your state rep or, the senator or the congressperson who represents you in your district and pushing them to advocate for you and to stand up for those policies that you feel like will bring about the change that we need.
Absolutely. And of course, it wouldn't be a conversation about Black maternal health without my toddler busting in at the very last minute. And I do want to encourage mothers who have had a difficult time or don't feel empowered to speak their truth. I brought my daughter with me when I went to testify on Black maternal health. And she was cutting up then like she's cutting up now, and we still made it happen. Don't let anything stop you from sharing your narrative and being a part of the solution. Dr. Moore, I want to ask you really quick, when can I stop breastfeeding? I'm tired. I know we're in a pandemic and you said that mothers should continue to breastfeed their babies, But she's a toddler. Should mothers do extended breastfeeding, or is it appropriate to wean them at a particular age?
I think that's an individual choice again, but I'd encourage to breastfeed, especially during pandemic, as long as possible. But it's an individual choice when women stop breastfeeding. So you guys will have to figure it out for yourselves. But right now, you know, baby, because, you know, baby's nursing for nurturing and not just nourishment. So that comfort's important, especially during this time. Even our children are affected by the anxiety of the pandemic. So it can be comforting for your little ones. So just hang in there a little longer.
Okay, I was hoping you was gonna say something else, but we will do what we can. Nonetheless, do you have any other final thoughts that you want to leave us with before we close out?
No, I just appreciate the opportunity to be on the panel. I just want women to know that at North Point, we are doing drive-through COVID testing. We also will do rapid testing for pregnant patients who are concerned about having COVID. We do have prenatal support services there and mental health services available for women during this time. So I want to let them know that's available, as well as lactation support in the community. We have it at North Point, and we also have the Chocolate Milk Club in the community for African American women. So there's resources out here, and I encourage women to educate themselves and use their resources.
Absolutely. And speaking of resources, Ms. Thornton, can you close us out with some more resources if folks want to get tested for COVID?
I can. So I want to just tell you, Brittany, that I breastfed my daughter until she was about 20 months old. And I'm convinced that that's why she's as healthy as a horse now. She rarely gets sick, and she is just a delightful little girl, but she is a mama's baby. So you just keep breastfeeding until she's ready to stop. So just a reminder that we should be maintaining the 3 W's. So wear your mask, wash your hands frequently, and watch your distance. That is the most important thing in preventing the transmission of COVID-19. We have multiple studies that show and prove that this works. And so if we do that, we can stop the transmission within our own communities. I also want to say to Dr. McKinney, and we talked about this on Monday, that I'm excited for the vaccine trials, and everyone on this call, if you're not pregnant and not going to get pregnant, please consider signing up for a vaccine trial. I have signed up myself and my 2 children because I understand the importance of having Black and brown bodies be a part of the data that comes out of those. So please, if you're listening to this, do some research. If you have questions, there are ways to reach any of us on this panel. We can talk to you, help you work through some of your questions, but we have to get Black and brown people in these trials. And then for our pregnant moms, please get your influenza vaccine. It is very possible for you to have COVID-19 and influenza at the same time. Therefore, it is quite imperative this season that you get your influenza vaccine so that if you do happen to get COVID-19, you are not hit with both of those at the same time while you're trying to produce and possibly birth a new body. And then there are free clinics listed in the chat, but there's one at Mount Olivet on Thursday and Friday of this week from 2 to 6. You do need to register before you go. I've included a link in the chat to the MDH clinic testing site. There are many all over the state, but also the link to the Mount Olivet test site is on there. And North Point Health and Wellness continues to offer testing to those who are symptomatic, exposed to someone with COVID, or someone who has participated in any of the social protests. The number is listed in the chat. It's also on their website. If you have symptoms of any sort that are unusual for you, please call your provider or go to one of these clinics and get tested. And I'm glad that we had this panel today. It's been very engaging and insightful, and I look forward to continued communication with all of you.
Thank you, Adrienne, and thank you to everyone on the panel for your time. Thank you to everyone who's watching virtually. I invite you to join us for our next conversation, which is happening 2 weeks from now on Wednesday, October 7th. It'll be broadcast from 11:30 a.m. to 1 p.m. Central Standard Time, live to the African American Leadership Forum Facebook page. This time we'll be talking about mental health and coping during a pandemic. Before we go, a special thanks to our sponsors, the Minneapolis Foundation, North Point Health and Wellness, and Children's Minnesota, as well as our partner organizations, the producers and the folks who come together to get this conversation going. That includes North Point, Children's Minnesota, Insight News, the Minnesota Spokesman Recorder, and Minnesota Community Care. My name is Brittany Wright, representing Insight News. There is nothing that I am more passionate about than Black maternal health. So this has been an absolute treat and a pleasure. Thank you for doing everything that you all do to make the world safe for Black mothers and essentially for Black babies as well. I hope that we can continue the conversation, and until then, be good to yourself and to the Black mothers in your life. Take care.